Hello and welcome. I'm Dr. Brian Kaufman, co-founder, executive vice president, and the chief medical officer of the nonprofit CLL Society. And I would like to welcome you to today's 6th annual Patient and Caregiver Educational Forum, brought to you in partnership with our friends at Huntsman Cancer Institute. We'd like to thank AstraZeneca, Beijing, Bristol-Myers Squibb, Janssen, and Pharmacyclics for making this forum possible through their grant support. I want to take a brief moment to review some of CLL Society's free educational resources for patients and caregivers. I'm going to quickly share a few, and if you have any questions, you can reach out to us at support@cllsociety.org. We have approximately 40 CLL patient and caregiver support groups across the country, and we just launched a new watch and wait specific support group with meetings beginning in December. I can't recommend these highly enough. Please check them out, and if you're not members, consider joining. The Expert Access Program provides a free telehealth second opinion appointment with a CLL expert physician. To apply, you only need to have a CLL or SLL diagnosis and be residing in the USA. We strongly recommend signing up for our weekly email for information on webinars, on-demand education, and breaking news relevant to those with CLL or SLL. Please visit the COVID-19 page on the CLL Society's website for recommendations specific to CLL patients regarding the pandemic, checklists in case of exposure, testing positive, or in the need to quarantine, and much more. We are now providing weekly updates in sourcing information from the CDC, the FDA, ASPR, and elsewhere on different variants of concerns. And our information, by the way, was just highlighted in a large article by CNN on the COVID pandemic. The Ask the Expert section is a really great resource where you can email your questions to our resident experts. Questions should be of general interest and not require a long explanation or detailed review of your medical history. That would be more for our Expert Access program. Lastly, I want to remind people of our Test Before Treat campaign. Please make sure you are getting the right predictive and prognostic testing completed before your first and every subsequent treatment. You can learn more on our website. It's now my pleasure to welcome Dr. Deborah Stevens, Assistant Professor of Hematology and Hematological Malignancies at the University of Utah and the Huntsman Cancer Institute, and a member of the CLL Society's Medical Advisory Board. Dr. Deborah Stevens.
Hi, everyone, and thanks so much, Dr. Kaufman, for the great introduction to our program today. I wanted to take a few minutes just to introduce the team here at Huntsman that helps to manage all folks that have CLL. Listed here are our doctors along the top. So myself, Dr. Hu, and Dr. Shah, who will be speaking today. But just wanted to point out Dr. Fitzgerald and Dr. Halwani, who weren't able to join us today, but are a really important part of our CLL team here. We also have several advanced care practitioners, and you can see their photos there: Renee, Bryn, Clayton, and Tara. So all of this group works together to help answer questions and to educate folks with CLL. Today we have a great program for you. We have a patient, Stephen Feldman, speaking about self-advocacy. Dr. Hu will be speaking about CLL basics. Dr. Harsh will be talking about what to watch while you wait. I'm going to be talking about CLL treatments and clinical trials. Then we'll have a brief message from Brandon Plew at our Huntsman Foundation, and hopefully have plenty of time at the end for question and answer session, and you can get all your questions answered today. So now, without further ado, I'd like to move into the program, and I'd like to introduce Mr. Stephen Feldman. He is a longtime CLL patient advocate working with the CLL Society. I'm really excited to hear what he has to talk about today.
Hello, everyone. My name is Stephen Feldman, and I am a CLL patient. I am a senior support group facilitator. I am the support group co-facilitator for the City of Hope support group, and I am also a member of the CLL Society Patient Advisory Board. A little bit about me. I'm 62 years old, originally from New York City. I've been living in California, Studio City, Los Angeles, since 2014. And a little bit of my educational background. I have a bachelor's degree in biology and a master's degree in counseling. I'd like to start my story, the diagnosis. I know everyone's going to think the big one should be CLL, but for me, it was a spinal cord injury that occurred when I was 23 years old. It was the result of a big word, arteriovenous malformation, abbreviated AVM, but best maybe understood as a spinal stroke. I had a bleed in my back that caused clotting that compressed the spinal cord, and the result was paraplegia, complete paralysis from the mid-chest down. And I have a picture of me there that's about 10 years old because it's one of the few pictures I have of me actually sitting in a wheelchair. It's an important and relevant part of my education that I didn't mention in the previous slide is that I was a chiropractic student. And putting aside the controversies that persist around the profession, the first year curriculum is very much rooted in the basic sciences, essentially identical to what's taught in medical school. So for me, it was like an immersive Berlitz course in the language spoken by healthcare professionals. So that was a big asset for me as I was learning about my spinal cord injury and interfacing with doctors and the like. So now the other diagnosis, the one we're all here to discuss today, and for me, it's the less big one, as it turns out, CLL. I was diagnosed when I was 54 years old. It came as a surprise during a routine physical. I had a slightly elevated white count. And when I did further testing, as we all do, I discovered that I was 13q deleted, and I had trisomy 12, and I was IGHV mutated. So mostly good prognostics. And I thought and hoped that I would be in watch and wait, which I call Weight Watchers, trademarked. I was hoping I would be in watch and wait for years and years, but it was only around 3 years before I started treatment in 2017. And I was given a combination of ibrutinib, also called Imbruvica, and obinutuzumab, which is more easily pronounced as Gazyva. I was in treatment for a whole year. And the good news is that I arrived at a complete remission, UMRD, undetectable measurable residual disease, as determined by flow cytometry. And then later on, I did a clonoSEQ, that's next generation sequencing, which is a much deeper dive to determine the depth of remission. And I had 5 CLL cells per 1 million leukocytes, white blood cells. So I hope that I will remain in remission for a very, very long time. So I was diagnosed while I was living in New York City. And what's important for my presentation is, which is about advocacy, is what did I do when I found out? Well, like everybody else, I hit the internet, which is a perilous place to be if you're discovering old information that's dated. But fortuitous for me, I discovered Brian Kaufman's blog. Dr. Kaufman, of course, is the co-founder of the CLL Society. And I had made email contact with him not long after I discovered my diagnosis. I then went on to discover a website called CLL Topics, which still exists, though it was discontinued in 2013. So the information on that website is more than dated. But that became my home, and that's where I really got rooted in all of the fundamentals of what CLL was and what kind of tests someone newly diagnosed should get, what the treatments were available at that time, which were hardly any. And then I was, before moving to California, I was able to get a consultation with a CLL expert named Rick Furman, MD, who's on the medical advisory board for the CLL Society. And we had a very fruitful, for me, consultation. And I recorded the consultation. It's an important thing to do, especially if you're newly diagnosed. When you're meeting with your doctor, you're not going to remember most of what he or she says. So by all means, you should ask to record it. Very few doctors will have any objection. So that leads to the next slide, the patient experience, taking the lead and learning from experts. So as you can see in the little center image, ask, listen, and learn. So again, I had lots of questions that I posed to Brian Kaufman via email, and he was very gracious in answering my emails. And again, I immersed myself to the best I could on the CLL Topics website. Next slide, lead and follow, follow and lead, sharing knowledge and experience. Again, I'm the co-facilitator of the CLL Society's City of Hope support group. It's named City of Hope because the City of Hope Medical Center was where our meetings were held prior to the pandemic. I had discovered, or first met Brian and learned about the CLL Society proper during the CLL Society's first ever patient education forum, which was held at City of Hope in 2015, I believe, in December of that year. And at that time, they were looking for volunteers to head up their second support group. We now have 40. And I won that competition because I was the only one that volunteered. And at that time, I was still very, very green about CLL, especially about treatments, which again, I hoped I would never need. I was very much the student to the members of the group who had far more lived experience than I did. They knew more about the disease and they certainly knew more about treatments. So like you, if you're showing up here for the first time, if this is your first patient education forum, kudos for attending. And you're taking an important step in cultivating your expertise in your unique CLL. The CLL Society experience. Community, we're in this together, patients and physicians. And much like the CLL Topics website was my home base when I was first diagnosed, I would hope that everybody who's joining us today will make the CLL Society's website their premier go-to source for reliable, current, physician-curated information. A lot of people, when they first discover they have CLL and do a generic Google search, will come across information that's dated, information that's looking backwards, not forwards. So they may, convince themselves that they have just a few years to live, and they get themselves into a tizzy. And as I like to say to many of my support group members, your anxiety didn't go to medical school. So it's very important to get physician-curated information. And I hope and encourage all of you listening, if you haven't joined one of our support groups, that you'll explore our website and do just that. The next slide, CLL Society resources, the clickables, as I call them. These are just a couple of screenshots from the homepage of our website. And the CLL Society website was recently updated, and I like to think of it as a veritable whole earth catalog on all things CLL. The website has grown into enormous and maybe even daunting proportions, but you don't need to master the whole website. Familiarize yourself with the areas of the website that are relevant to your situation. The alphabet soup of terminology will become second nature over time. You will become increasingly aware of all the advances in treatment and return often. Takeaways, important takeaways from the CLL Society. Watch and wait is your friend. This is your time to get up to speed. Wisdom and advice from those who traveled the path. You'll find those people in your support group. Clinical trials. Many people have unique circumstances. Clinical trials are the fertile ground for discovering new treatments, often at a reduced cost. So please explore our website on that. And the CLL Society's prime directive, have a CLL specialist on your team, accept no substitutions. Again, I was fortunate to have met a CLL expert very early in my journey, even before I started treatment. So I was sort of up to speed and ready to go. So if you're living in a community where you may not have a CLL expert, do make a point of checking out the CLL Society's Expert Access Program, which you can access from our homepage. Last thoughts. This is not your father's Oldsmobile. It's also not your father's CLL. Everything has changed. In 2014, ibrutinib was approved. That may have been the first non-chemo targeted treatment available, and there have just been a slew of treatments that have come online since then. You can and will likely live a long and healthy time with bad news. Terry Evans, a name whose name may appear somewhere during today's presentation, he's the director of our support groups, and he has had CLL for 20 years. Brian Kaufman was diagnosed maybe 14 or 15 years ago. My CLL will have reached its, I think, 9-year mark this spring. And I often say to people, if it were not for my continuing involvement with the CLL Society, I don't even know that I would think about my CLL anymore. I do show up for my biannual checkups, but they're, fortunately for me, all quite boring. I recently marked the 39th year of my paralysis. How did that happen? That's a long time to live with pretty bad news. So on paper, I'm a health catastrophe. In real life, despite paralysis and my CLL, I remain in excellent health. So I hope that is a meaningful takeaway for all of you listening today. And so at this point, with my history as a backdrop, I want to take a moment and steal the microphone away from myself to discuss the elephant in the room. It's the elephant that's in every room. It's the herd of elephants that surround us all, and that is, we're going to die someday. Surprisingly or not surprisingly, the topic of death and dying rarely gets discussed during our support group meetings. It's become something of a cliche. You'll hear it, many doctors say, and other patients say, that you'll most likely die with your CLL and not from your CLL. And that's true, but we're all still going to die someday. So it's important to remember that CLL is not the cause of your anxiety if you're experiencing it. It's just revealing it. Part of the human condition is the awareness of our mortality. Your diagnosis then is an opportunity. It's a guru that can deepen your appreciation of life if you can allow for it. Because this show does come to an end, that is life, at some point. In that sense, your CLL is an opportunity to front load your awareness and appreciation, not only of your disease, but of your limited time, our limited time between our birth and death, our life. So I hope that's not too heavy. And depending on what your orientation is, if you're philosophically minded, spiritually minded, religiously minded, I'm not the CLL chaplain, but I hope you'll consider those thoughts as you move forward. And that's my story. And I appreciate you listening, and I hope it was all helpful. And next up is Dr. Boyu Hu. Take it away, and thank you.
Hello, everybody. Thanks so much for having me today. My name is Boyu Hu, and I'm an assistant professor here with the Lymphoma CLL group. I'm going to present to you some basics about CLL. So what is CLL? It's usually a slow-growing blood cancer, In order to understand CLL, we do need to understand the components of the blood that are cellular components. So there are 3 different types of cell lines in the blood. One is red blood cells, which carry oxygen. Having low red blood cells is also known as anemia. We have smaller cells known as platelets that help to form blood clots, and having low platelets is called thrombocytopenia. And lastly, we have white blood cells that help to fight infection, and CLL is a cancer in a specific type of white blood cell. And so we actually have many different types of white blood cells that have many different functions. And specifically, CLL comes from white blood cells that are known as lymphocytes. Lymphocytes normally help to fight infection and especially viruses. And even more specifically, CLL comes from B lymphocytes, which are responsible for memory. So if you ever get a vaccine or an infection, your body actually remembers that vaccine or infection by producing these memory cells that in the end produce antibodies or proteins that circulate in your blood, so that if you ever get that infection again, it's more readily able to fight that infection. And so just some CLL epidemiology. It is the most common adult leukemia. It accounts for about 1/3 of all new leukemia cases. It's still considered a relatively rare disease, though, in the grand scheme of things, as compared to breast or lung cancer, for example. But in 2019, the American Cancer Society estimates about 20,000 new cases of CLL. However, only about 4,500 patients per year die of CLL. And this number is actually going down every year, given our new advancements in treatment with targeted therapies, CAR T, et cetera. Again, it's a relatively rare disease, and so the average person's lifetime risk of getting CLL is 1 in 175. It is a disease of aging, and so the average age of diagnosis is 70. And for sort of unknown reasons, it's more common in men in a 2-to-1 ratio as compared to females. So again, risk factors that predispose someone to developing CLL, including male sex, white ancestry, and it is about 5 times more likely for Caucasians to get CLL than Asians. And in other epidemiological studies, Asians, whether they live in the US or Asia, are the lowest risk, suggesting that genetics are more important than environment in developing CLL in a person's lifetime. Also, family history of blood cancers does predispose somebody to CLL. Very rarely, so only about 5% of cases are familial, meaning that it's passed down from parent to child. However, just having one relative, close relative, that has either non-Hodgkin lymphoma or CLL increases the risk of a patient having CLL as well. It's sort of unknown what these risk factors are. It's probably a combination between genetic risk factors, environmental, that kind of contribute to the fact that non-Hodgkin lymphoma and CLL can run in families. So what is a typical clinical course? Many patients are actually discovered incidentally, meaning that they come in for a completely different reason and with no symptoms, and they're diagnosed on routine blood work. So this could be an annual physical where the primary care doctor gets a complete blood count and notices something is slightly off on their complete blood count. However, if patients were to have symptoms on presentation, they could have lymph node swelling, and we'll talk about that just a little bit. Fatigue, B symptoms, including fevers, drenching night sweats, and unintentional weight loss. And some findings on exam include enlarged lymph nodes and enlarged liver or spleen. So we talk a lot about lymph nodes in CLL and the blood as well, but what are lymph nodes? Well, they're part of the lymphatic system and a vital part of the immune system. They are the houses in which contain the white blood cells and the CLL cells. And it's the area in the body that predominantly is fighting infection. So if you ever get a cold or a sore throat and you feel some swollen glands in your neck, those are the lymph nodes doing its work. We actually have many lymph nodes on our body, 500 to 700, that follow our blood vessels. So wherever you have blood vessels, you have lymph nodes as well. So just to give you a typical clinical case that we see, a 60-year-old male presented to a doctor for yearly physical exam. Routine labs show white blood cell count of 40,000. Normal is between 4,000 and 10,000. The lab reports 88% of these as abnormal lymphoid cells. His other blood counts are normal. The doctor suspects CLL and the patient is referred to Huntsman. And so what is necessary for diagnosis? Well, what I'm showing you here are blood smears. So if you take a drop of somebody's blood and you look at it underneath a microscope, on the left there is a normal blood smear in which you see red blood cells mostly throughout the slide. The small little dots there are actually the platelets I was talking to you about that helps to clot blood. And the larger cells with the lobes in the middle there are white blood cells, and those mostly are neutrophils in this normal blood smear. In a patient with CLL, we see a lot more of these small lymphocytes, these small blue cells in between the red blood cells. That's because the lymphocyte number is much higher in these patients. And so morphologically or shape-wise, they look like these small blue cells. We also see quite a bit of smudge cells, and this is an artifact of producing the blood smear. This is not how a CLL cell looks in blood. But because these CLL cells are more fragile, in the preparation of the blood smear, they can smudge like this. But it can be a sign of CLL when looking at a blood smear. And so for definitive diagnosis, we will actually send the blood for a test called flow cytometry. Flow cytometry is a special test that looks at what proteins are expressed on a cell. And so this is important because, for example, in CLL, the proteins that are on the cell surface include CD5, CD20, and CD23. CLL cells also importantly do not have or do not express CD10 or cyclin D1. When we see this combination on the flow cytometry and look at the morphology in these being these small blue cells, we can pretty definitively make the diagnosis that the patient has CLL. The other important part I'd like to note is that the number of CLL cells in the blood must be 5,000 or greater to have an official diagnosis of CLL. If a patient comes to us with less than 5,000 leukemia cells in their blood, they actually have a pre-cancer state called monoclonal B lymphocytosis. So what other workup may a patient require at initial diagnosis? Most of the time, it's going to be nothing else. It's going to be just some blood work and none of these more advanced tests that I'm going to be talking about. However, sometimes patients do require them, whether they go on clinical trial or because we need to figure out what's causing this, either their symptoms or their low blood count. This test may include a bone marrow biopsy in which we put a small needle into the back of the hip to take blood and a small chip of the bone directly from the bone marrow. The bone marrow is the factory for all the blood, and so sometimes it's important to sample that area. We may also get a CAT scan to evaluate if a patient has swollen lymph nodes or swollen liver or spleen. And not very common, but while CLL is mostly a slow-growing disease, it very rarely can transform or become a more aggressive lymphoma known as Richter's transformation. And in order for us to figure out which area to biopsy to determine if a patient has transformed to the more aggressive lymphoma, we may perform a PET scan. So this is rarely done for CLL. Mostly we'll do a CAT scan if we want to look at what areas involvement, but this may be necessary in a patient's clinical course. So I get asked a lot, what is my stage for my CLL? So staging is very different for CLL because it is a blood cancer. So it is all over your body already because it's circulating in the blood. So very early on in the 80s, Dr. Rai came up with a staging system to help to stratify patients into low, intermediate, or more high risk. And this staging system is a stage 0 to 4. And it includes if a patient just has high lymphocytes over 5,000, if the patient has enlarged lymph nodes on exam, enlarged liver or spleen, or if they're anemic with a hemoglobin less than 11, or thrombocytopenic with a platelet count less than 100,000. However, in general, CLL staging is not that useful. While it's helpful for prognosis and whether a patient may need treatment, it doesn't actually guide us on what treatment to specifically give that patient. So we may talk about staging during our visits, but again, in general, at least nowadays, it's not super helpful in terms of the staging. So back to the patient that I presented before, his flow cytometry confirmed the CLL. His lymphocytes are greater than 5,000, so he has an official diagnosis of CLL. He has enlarged lymph nodes on exam, so he has a rise stage 1. So what other tests might be helpful? And so these are some of the prognostic factors that we typically send here at Huntsman at initial diagnosis and at other certain times as well. These are usually changes in the DNA or genes that are only found in leukemia cells. These are not gene changes or mutations that are inherited from your mom or your dad, or you can pass on to your kids, but really specific to the leukemia cells itself. So what we typically send for, and I'll talk about these in just a little bit, includes FISH, immunoglobulin heavy chain variable region mutation status, karyotype, and also specific CLL gene mutation. So what is FISH and what does it mean? So in a normal cell, you have one pair of each chromosome. And so remember, back to biology, we have 23 chromosomes, and having a pair of each gives us 46 chromosomes total in our body. Usually these are paired very nicely together. They all look symmetrical, all look the same. However, something happens in normal cell division to cause CLL. And one of the things that may happen is that the cell may actually lose part of one of the chromosomes. So one arm, a small part of that arm gets lost for some reason during replication. The other thing that may happen is that the cell may actually pick up an extra copy of a chromosome to actually have 3 copies of a certain chromosome instead of just having 2. And so what we can do is we can use FISH to figure out if certain areas of the chromosome have been removed, or there's an extra chromosome in the CLL cell. And so what we look for are 4 things on our FISH panel. It includes deletion 13q, trisomy 12, or 3 copies of the 12th chromosome, a deletion in the long arm of the 11th chromosome, deletion 11q, and deletion 17p, which is a deletion in part of the short arm of the 17th chromosome. And this is what the test kind of looks like on the bottom right here. You can see that our FISH probe kind of lights up 3 copies of the 12th chromosome, giving us trisomy 12, which is 3 copies of the 12th chromosome. And these FISH panels, these FISH findings do have prognostic value. So traditionally, deletion 13q was a good prognosis CLL. Trisomy 12 was somewhere in between, and then deletion 11q, deletion 17p did have worse prognosis prior. I'm just going to be brief about IGH mutational status. Being mutated is great. Being unmutated is not as good. Most patients who have IGH mutated status can go without any treatment. They can be observed for the rest of their lives. But however, patients who are unmutated, only 20% do not require any therapy. So that means 80% will require some therapy at some time. However, the outcomes for IGH mutated and unmutated patients now are about the same when most patients now are treated with our targeted therapies. So targeted therapies have really leveled the playing field for IGH mutated and unmutated patients and have made their outcomes in terms of survival very similar. We also will send for specific CLL gene mutations. What we most commonly find are mutations in TP53, ATM, SF3B1, and Notch1, and less common in these other genes that I showed you here. At Huntsman, we have a 27 gene mutation, so we only look at 27 genes. There are many other genes that can be mutated. You know, we have tens of thousands of genes in our chromosomes. And so we only look at 27 of them. But these gene mutations are specific to CLL, are probably the most common ones that we find in CLL. When we send for this test, it takes about 2 to 3 weeks for it to result. So when do we send for these tests? Most of the time at diagnosis. And then also after some treatment and before the next line of treatment, if these tests are going to change our management or what we decide to give the patient as their next line of therapy, or potentially what clinical trials the patient may qualify for. So IGHV mutational status is static, meaning that whether you're mutated or unmutated does not change with therapy. So we actually only just send it once at diagnosis. However, other things like FISH, karyotype, and mutations can change over time and with treatment. So we may choose to repeat any or all of these tests after certain lines of treatment and before we decide to either enroll patients onto a clinical trial or give them other treatments down the line. So just some of the basic takeaways from this talk is that CLL is the most common adult leukemia that affects mainly the blood, bone marrow, and lymph nodes. Monoclonal B lymphocytosis is a precursor state or precancerous state to CLL, and is when the number of leukemia cells in the blood are less than 5,000. So patients don't necessarily have that official diagnosis of CLL unless that number is 5,000 or greater. There are many imaging and genetic tests that we may choose to perform at diagnosis and also at relapse. However, we may also not do them initially. These testing gives us both prognostic data and also may guide treatment selection in the future. So I want to thank you for your attention today, and I'll take questions at the end. I'd like to introduce my colleague, Dr. Harsh Shah, who will be presenting to you about the watch and wait period in CLL. Thank you.
Hello, everyone. My name is Harsh Shah, and I'm one of the CLL physicians here at Huntsman Cancer Center. And today I'll be discussing watch and wait strategy in CLL and what we do during that time. So these are the learning objectives from this short talk. First, we will talk about watch and wait, why we do it, and what we exactly do during that time with our patients. Then I'll start focusing on vaccinations that are recommended during watch and wait, some of the secondary cancers that are common, or screening procedures that are needed for CLL patients. We'll spend a short amount of time on diet and exercise for CLL patients, and then obviously everyone's favorite, we will discuss COVID-19 related updates in terms of the vaccines and antibodies and treatments that are available for CLL patients. So here we go. So when do we treat CLL? Obviously, as many of you may be aware of this, not everyone with CLL gets treated when they're diagnosed. We usually only recommend treatment if with CLL, if patients have progressive bone marrow failure with decrease in their red blood cell count or platelet counts, called low counts. Secondly, if patients start developing B symptoms, such as combination of fevers, drenching night sweats, or weight loss that are significant, then we also consider that as a reason to treat CLL. And then, when patients develop lymph nodes that are bulky, that are causing pain or discomfort, or they're causing some sort of end organ damage, then we may consider treating those patients. And then also for patients who have increase in their spleen size that's causing symptoms such as weight loss or pain, then we would also consider starting those patients on treatment for CLL. The reason for selecting only those patients for treatment is that CLL is considered, at least today, still considered incurable. The treatments have improved over the years from chemotherapy to targeted agents where we can get patients into remission for a long time, sometimes 5 years, 10 years, or even longer. However, CLL does tend to come back at some point. So it's still, considered incurable. And obviously there are patients who are low risk CLL, and those patients may not need treatment throughout their lifetime. So, obviously there is no point in starting treatment in these patients. And then lastly, there have been studies done which have looked at giving chemotherapy in patients who do not have symptoms from CLL. And those studies largely have shown that starting someone on traditional chemo, if they don't have symptoms, it does not actually improve their survival. However, obviously this may be changing with novel agents such as BTK inhibitors or venetoclax, which is a BCL2 inhibitor. We are starting to do trials such as the one listed here, S1925, which is a SWOG trial where patients who have really high risk CLL, there is a 50% chance that you would be randomized to treatment, and there's a 50% chance that you would be going on watch and wait. And the primary endpoint of that study is to see if that actually improves how long patients live. So it'll be interesting to see if doing these kind of novel treatments early actually improves overall survival. But currently, obviously, no treatment is recommended for patients who do not meet criteria for treatment. What do we do during watch and wait? Well, depending on whether your CLL is considered low risk or high risk, which is based on your, IGVH mutation, status of T53 mutations, and several other factors, we can categorize patients into low risk, intermediate, or high risk patients. And that's basically telling us, which patients will need treatment sooner rather than later. So patients who have high risk CLL traditionally would need treatment sooner rather than patients who have low risk CLL. Although obviously it's not always, always doesn't pan out that way. But we may see patients either every 3 months if they're high risk, 3 to 6 months, or if they're low risk, then we may see them every 6 to 12 months to basically go over the blood work where we look at the white cells, red cells, and platelets. Then we also do a physical examination where we examine lymph nodes and spleen size, and then we also go over your symptoms. So that's what we do during watch and wait. We also do not routinely recommend scans while patients are on watch and wait because there can be a lot of false positives with doing scans. And in the absence of symptoms, doing scans, obviously it's not feasible because of exposure to radiation that's unnecessary in CLL patients. So that's basically the gist of what we do when patients are on watch and wait in terms of seeing them. We also do several other things that we'll talk about now. And one of the first things is vaccinations. Patients who have CLL, their immune system is compromised. So they're especially prone to several infections. So we recommend, obviously, we do not recommend any live vaccines. However, we do recommend Tdap vaccine every 10 years. We definitely recommend a pneumonia vaccine. In the past, we used to do PCV15, which was followed by PPSV23 vaccine, which is the polysaccharide version, about 8 weeks later. However, just this year, FDA has approved pneumococcal conjugate vaccine, which is PCV20, instead of doing the PCV15 followed by PPSV23. So we're sort of, obviously, if someone has gotten PCV15 in the past, then we would we would try to do PPSV23. However, for most of the other patients who are starting their pneumonia vaccination series, we are just recommending PCV20 now. Now, talking about pneumonia vaccines, we do have a clinical trial at Huntsman called Protect, where we're checking actually to see if patients with CLL are able to make antibodies against pneumonia after getting the vaccine. So this is definitely a trial that you should ask your physicians about. We definitely also recommend Shingrix vaccine after age of 50, and then we recommend annual influenza vaccine. Obviously, we also do recommend COVID vaccines, and we'll talk about that at the end. Now, as far as the cancer screening goes, we recommend age and sex appropriate cancer screening in all patients. So for colon cancer starting at 45, for mammograms starting in females starting at 40, pap smears for sexually active women every 3 to 5 years based on the guidelines. And then there has been several publications that have noted that there is increased risk of melanoma and non-melanoma skin cancers, such as basal cell cancer or squamous cell skin cancer. And that non-melanoma skin cancer risk is as high as 10 to 15%. And in preclinical studies, there is a vitamin called nicotinamide, which is a derivative of vitamin B3, that has shown some evidence that it could be helpful in preventing the non-melanoma skin cancer. So we have a clinical trial here at Huntsman where in patients who have history of non-melanoma skin cancer within the last 5 years, they will have a half chance of getting this nicotinamide drug, and other half will go on placebo. And then after a certain amount of time, everyone will get the nicotinamide drug. So I think it's a very interesting and unique study that for CLL patients who are on watch and wait in order to prevent these non-melanoma skin cancers. Obviously, we recommend annual skin exams in all patients with CLL because of this increased risk of skin cancers. And then we also recommend sunscreen for our patients. Now, briefly, just touching base on diet and lifestyle, most of the patients with CLL succumb to something else other than CLL. Those things can be heart disease, stroke, kidney disease, obesity, diabetes. So it is very important to obviously staying in touch with your primary care physicians and making sure that we take care of these things and have routine follow-up. Also, sunscreen and skin protection that we talked about. As far as the diet, we just recommend AHA guidelines for diet and exercise. For diet, just eating overall healthy diet with wide variety of fruits and vegetable. Whole grains are good. Healthy source of proteins, such as nuts, fish, and seafood is good. And then we recommend minimally processed foods and minimize intake of added sugars, especially for stuff that's bought in the grocery stores. As far as the exercise, we recommend about 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise for anyone who can. So those are some of the general recommendations for diet and lifestyle. Now, lastly, I want to briefly touch base on COVID-19, which is obviously the hot topic all over the world. This is the map from the FDA, from the CDC website, looking at the COVID variants in the Mountain West region, which includes Colorado, Montana, obviously Utah, Dakotas, and Wyoming. And as you can see, starting from July to now, there has obviously BA.5 is the most common variant, but there have been other variants such as BA.4/6 in blue and then BQ.1 variants in green that have been becoming more prevalent and are probably going to take over in the near future here. So that's one thing. Secondly, for COVID-19 prevention, so as we know, previous vaccines, they protected us against the beta and delta variants, which were common initially. However, Omicron variant has sort of taken over, which is the BA4 and BA5, and uh, there have been new vaccines from Pfizer and Moderna that are now also protecting against the Omicron variants. So those are the bivalent COVID-19 vaccines. They have been approved for patients who are age of 6 or older, um, for all patients, but they have to be done about 2 months after another COVID vaccine. So there has to be about 8-week period before you can get this COVID-19 bivalent booster, which we recommend for all of our CLL patients. Um, um, Obviously, in a clinical trial, it showed that doing the bivalent COVID vaccine, it produced more antibodies against these newer variants than the older vaccines. Now, Evusheld, I think a lot of you have heard about that. It is a pre-exposure prophylaxis against COVID-19. So for patients who have not had COVID-19 in the recent times, um, it's a monoclonal antibody. It's a combination of two different antibodies that has been granted authorization for emergency use in CLL patients and other patients. All CLL patients are immunocompromised, so they are qualified for this. They recently changed the dose from 150 to 300 milligrams. Um, and it is now recommended to be given every 6 months. It does provide protection against the BA5 variant, which obviously represents currently about 50% of the COVID-19 variants in USA. However, obviously, the BA5 variant is falling, so I think it would be important to see what the FDA recommends in the future about Evusheld. But currently, we recommend it every 6 months. And then the outpatient treatment. So there has been a change, obviously, a change in the last year. Antivirals, which target specific parts of the virus to stop it from multiplying in the body, have been approved. And then one of the most common one is Paxlovid, which is a oral pill. Um, it is approved for mild to moderate COVID-19, and in a clinical trial, it reduced hospitalization by about 90%, which is great. One thing to note is that it does interact with CLL medications such as ibrutinib. So obviously it is important to discuss with your CLL physician before you take this drug to see if you need to hold your CLL medication. Now, there is an IV antiviral called remdesivir that has been sort of been approved for a long time for inpatient use, but now it's also approved for outpatient use. It's given IV over 3 days. And then recently, there's another antiviral called molnupiravir or Lagevrio, which has been approved, especially with the shortage of the Paxlovid. This has been also sort of come in handy in patients who cannot get the Paxlovid. Monoclonal antibody is also approved to be given as outpatient for COVID-19 treatment. And the one that's approved currently is bebtelovimab. It's a single infusion. Important to note that it may not provide provide enough protection against newer variants. So those are the the outpatient treatment for COVID-19 that we currently have. Um, these are the general guidelines for outpatient COVID-19 treatment. So obviously you have to test positive for COVID. The treatment has to begin within 5 to 7 days, depending on what treatment that you're going to be qualified for. So it is always important to let your CLL physician know once you get diagnosed with COVID-19. You cannot be on any new oxygen. So if you're on oxygen at baseline, that's fine, but you cannot have increased oxygen requirement to qualify for these drugs. You cannot be hospitalized, obviously. And then obviously all CLL patients are qualified for these drugs because they're inherently immunocompromised. So I mean, I think that's really it in terms of what I wanted to discuss today. Conclusions are that, uh, obviously work with your healthcare team in making sure that you understand watch and wait process, and all your questions get answered, because we see is that anxiety can be increased during watch and wait, but it's always important to discuss everything with your physicians, and usually learning more about CLL or learning more about what we do during watch and wait does help in reducing the anxiety and stress levels. So, secondly, obviously get up to date on all the routine vaccines. Make sure we do yearly skin exam with a dermatologist. Eat a healthy diet and exercise, and then obviously everyone should get COVID-19 bivalent booster if it's safe for you, and then Evushell is currently recommended every 6 months for pre-exposure prophylaxis for all CLL patients. And with that, I'll conclude, and then I want to welcome Dr. Deborah Stevens to give us a talk on current treatments for CLL. Thank you.
Hi again, everyone, and thanks again for the introduction. And just wanted to let you all know that I'm really appreciative of you all being here to learn more about your CLL today. I have kind of a big topic to cover in a small amount of time, so I'm really going to try to cover the basics and the highlights and leave plenty of time for questions at the end so you can get your specific questions answered. But I will be talking about CLL treatments and clinical trials today. First, I want to start out with current treatment options, and I'm going to start more on the basic end because you all know there are three kind of general cancer treatment options. When we think about cancer treatment, surgery is sometimes an option, but it's not for CLL just because there's no way to cut out all of the disease that's circulating around in the body. And similar for radiation, just because since CLL is not localized to one body area, it's not realistic to radiate all of the CLL disease. Now, sometimes and rarely we can use radiation if we need a quick response to a lymph node that's causing particularly pain, but generally we don't use it. And so that we're really left with kind of this big group of drugs called chemotherapy, which is the usual choice for CLL treatment. Of course, it makes sense because if you have a blood cancer, you want to be able to reach all of your blood. And so that's what these kind of treatments do. I'm going to break it down into classic chemotherapy, immunotherapy, and targeted therapy today. So when I refer to classic chemotherapy, I think about drugs that have a really non-specific killing of growing cells. And that means that these drugs go into the system. They do kill CLL cells, but they also kill some normal cells. And your body's repair mechanisms have to grow back the normal cells. So these are drugs like fludarabine, cyclophosphamide. If you've ever had FCR, that's the F and the C. Bendamustine, if you've ever had BR, that's the B of BR. And not used quite as much anymore, pentostatin and chlorambucil, but they all fit into this category. Short-term side effects of these drugs can be nausea, hair loss, fatigue, low blood counts, infection, nerve pain, such as neuropathy or blood in the urine. These are bothersome, but generally resolve quickly. The long-term side effects are the ones that I worry more about because obviously we want people to live as long as possible with as much quality of life as possible. And long-term side effects, a rare side effect of these chemotherapies is causing bone marrow damage. This can lead to something called myelodysplasia or scarring in the bone marrow, and can even lead to acute myeloid leukemia, which is a very serious and fast-growing type of leukemia. And while this only happens in about 5% of patients, I generally try to avoid this type of chemotherapy just because we have a lot newer options, and I really want to avoid that side effect for patients if I can. I'm going to touch on immunotherapy. There are obviously lots of new immunotherapies under development, but I wanted to talk about the currently approved immunotherapies for CLL first. These are, specifically targeting sometimes things that live on the outside of the CLL cell, and the classic immunotherapy for CLL are called monoclonal antibodies. The antibodies I've listed here are rituximab, ofatumumab, and obinutuzumab. These are all antibodies to something called CD20, which lives on the surface of CLL cells. You can see kind of a cartoon here of an antibody, and the top half, its job is to recognize the cancer. So in this case, it recognizes CD20. And then the bottom half, it is the part that tells the other immune cells to kill the cancer. So you're essentially just drawing attention to these cancer cells for your immune system to kill them. We're going to talk about some newer immunotherapies coming up in the next segment. When I speak about targeted therapy, these are the drugs that are most often used now in the treatment of CLL. The goal of these kind of treatments are to avoid killing normal cells and to really go specifically after the cancer cells or something that keeps them alive. When I talk about targeted therapy, I'm referring to drugs such as ibrutinib, acalabrutinib, zanubrutinib, idelalisib, or venetoclax therapy. I'm going to first start talking about the targeted treatment, Bruton tyrosine kinase inhibitors. This is a very commonly used class of drugs and a very effective class of drugs for people who have CLL. When I think of these drugs, there is something in your body called the B cell receptor signaling pathway. And that is the pathway that sends survival signals to your CLL cells. And obviously, we don't want your CLL cells to survive. And so we want to block that pathway. Bruton tyrosine kinase is part of that pathway. And so by using these BTK inhibitors, we're blocking that pathway. And I think of it like taking the gas out of your car. So your CLL can no longer go anymore. These include ibrutinib and acalabrutinib, which are approved for all patients with CLL. And there's a drug called zanubrutinib, which is a similar drug, which is most likely going to be approved for CLL soon. I can't leave this class of drugs without talking about a few of the toxicities. And the reason why is because this class of drugs is a class of drugs, they're pills and they are taken indefinitely. That means they're meant to be taken unless they're not working anymore or there's side effects or, potentially something better could come along, and that's why you might stop this therapy. I think of therapies in terms of what time do they show up while you're taking these drugs. And so I'll highlight a couple of common early toxicities, and these are arthralgia, infection, and diarrhea. And the good thing about these, they do go away with time. And so if you can manage these symptoms, usually after the first month or two, these symptoms will get a lot better on therapy. The light blue color highlights side effects that come on later, and these risks do increase over time as long as you're on the BTK inhibitors. One is an irregular heart rhythm called atrial fibrillation. Now this is manageable through medications that lower your heart rate and potentially blood thinning medications. And then high blood pressure. So blood pressure can increase over time, and it often takes adding a new blood pressure lowering medication to help combat this high blood pressure. And then in the darker blue, something that can happen at any time is bleeding. And so bleeding and bruising are very common, and you really need to let your doctor know if you have a planned surgery so that they can advise you on when to hold this medication before or after the surgery. I'll just make a note that ibrutinib probably has the most of these side effects, and there are less toxicities with acalabrutinib or zanubrutinib. So if you're having toxicity to ibrutinib, you may want to talk with your doctor about considering switching to acalabrutinib or even zanubrutinib. Another class of medications, venetoclax, is the only drug in this class. It's called a BCL2 inhibitor. This is also an oral pill, and the strategy is a little bit different here because it is a time-limited strategy. So patients only take these medications for either 12 months or 24 months, depending on what line of therapy they're receiving. So the concept of this, there's something called BCL2, which is a protein that CLL cells express, and they do this because they want the CLL cells to live forever, and it causes them really to live longer. And so what venetoclax does is it comes in and blocks that protein, and it causes us to really tip the scales into causing the CLL cells to die. Venetoclax is approved for all patients with CLL in combination with some of those anti-CD20 monoclonal antibodies that I spoke about previously. Some of the toxicities I want to highlight that are a little bit unique to venetoclax is something called tumor lysis syndrome. This is essentially the drug working really quickly and really fast, and your body can't handle all those waste products that come out of the cancer cells when they die. And so at the very beginning, this is why we usually give this drug at a really low dose for the first week, and then we have 4 more weeks of ramping up to our target dose. Also staying really hydrated and getting drugs to prevent uric acid buildup like allopurinol. Occasionally, some patients have to be hospitalized to manage for this because too many of these waste products like potassium or uric acid can cause damage to the kidneys. Another common side effect are diarrhea and nausea. Usually anti-diarrhea or anti-nausea medications are a big help with this, or even taking the dose at night as opposed to in the morning can be helpful. Other thing that can happen are low infection-fighting white blood cells or neutrophils or platelets. This is what your doctor is monitoring for when they check blood work. And if you have a low white blood cell, they can give growth factor injections to help boost that up and lower your risk of infection. Infection is a risk for these drugs because it does suppress your immune system, and it does prohibit you from making a vaccine response, especially when given in combination with monoclonal antibodies like rituximab or obinutuzumab. So try to recommend if you're getting vaccines, try to do that before starting treatment. You know, if you were to develop an infection, I'm a little bit quicker to give antibiotics and really ask all my patients to monitor for fever. But overall, despite these side effects, most people do really well with the venetoclax medication. And so again, kind of the strategies that we have to treat CLL, there is continuous therapy with BTK inhibitors. And again, the goal of that therapy is kind of disease control and to result in prolonged remission or inability to detect any cancer cells. Or we have a fixed duration with drugs like venetoclax. And the goal of that therapy is really to cause the deepest amount of response possible in a shorter period of time and can lead to something called undetectable minimal residual disease. And therefore, you can have breaks in therapy. So if you receive venetoclax in the first line setting, so first treatment for CLL, you receive it for 12 months. If you receive it later down in other lines of therapy, you would receive it for 24 months. And there is some evidence that after you stop it and your disease comes back, you may have the opportunity to take venetoclax again and your CLL might still respond to it. So those are the general treatments that are available right now. I'd like to take a couple of minutes to talk about some new treatment approaches. And these are currently available on clinical trials, but not available as standard of care just yet. One of the hot topics right now is how do we combine these new drugs to make them more effective? And so kind of the concept here is pick 2 or 3 of these good drugs and combine them. So maybe we would use one of the BTK inhibitors plus a BCL2 inhibitor plus or minus an anti-CD20 monoclonal antibody. And you know, the question we're really asking, is it better to give these all together, or is it better just to give one, wait until the disease comes back, and then give another? And so some potential advantages of using the combinations are, could we get deeper or longer lasting responses? And in the case of BTK inhibitors, could we combine it so that we can shorten that treatment length so it's not an indefinite therapy? Another thing I'm very interested in studying is early treatment. Dr. Shah had already talked about patients who are on the watch and wait plan. And this particular clinical trial called the S1925 EVOLVE study, it's specifically for patients with CLL who have some high risk features. So either have a deletion 17p, a TP53 mutation, or a combination of clinical and genetic risks that are considered high risk. Patients must have been diagnosed within the last year. And what's unique about this study is when you enter the study, you get randomized and you either immediately get treatment with obinutuzumab and venetoclax, or you wait until a time when you develop symptoms or cytopenias, which is the current standard of care. What's nice about this trial is it does offer early treatment, especially for people who are at high risk of progressing quickly with CLL, and all of these drugs are paid for by the study. If you think you might qualify or if you have questions, I'd be happy to answer questions about this clinical trial. The other thing I want to highlight is, so what happens when a BTK inhibitor doesn't work anymore? And so some of you may have experienced a relapse or progression of CLL while on ibrutinib or acalabrutinib. And what happens is the drug binds to a site on BTK called C481. So what happens when the cells, the cancer cells are trying to become smarter than the chemotherapy drugs, and they mutate that binding site. So the most common mutation site is something called C481S. And so the drug, I put a keyhole analogy up here because the drug should nicely fit into the keyhole. But when it mutates, maybe the key still fits, but it's not really a tight fit. And so what you often see when patients have a relapse is kind of a slow progression of disease. So a little bit of increase in white blood cell, a little bit of increase in the size of the lymph nodes. But if you just stop that BTK inhibitor, you will have rapid progression. So don't stop the BTK inhibitor without another plan in place. And this applies to ibrutinib, acalabrutinib, and zanubrutinib. I wanted to highlight some of the newer or next generation drugs because I've already said ibrutinib, acalabrutinib, zanubrutinib can develop resistance over time. There are some next generation BTK inhibitors like pirtobrutinib and ARQ-531 or nemtabrutinib. And they have open clinical trials right now showing great responses in CLL, even after drugs like ibrutinib, acalabrutinib, and zanubrutinib don't work. We also have an exciting clinical trial with a new BTK inhibitor called LP168, which the clinical trial is open and enrolling and have had some great responses so far. Also wanted to highlight a drug called MS553, which we're studying here and a few other centers across the country. It's kind of a similar concept to the BTK inhibitors because, as I mentioned, BTK inhibitors block CLL survival signals. And PKC beta inhibitors like MS553, they block CLL survival signals in a different spot of the survival pathway. So this is a promising pill that works when ibrutinib or other BTK inhibitors no longer work, and the clinical trial is currently open here at Utah. I just want to spend a little bit of time talking about CAR T cell therapy. The concept of CAR T cell therapy is the CAR T cell essentially recognizes something on the surface of the cancer cell. In the case of the most advanced one, this is called CD19. Then the CAR T cell activates the immune system to kill the cancer. What it looks like on the patient side is patient's blood is collected, the T cells are separated out, and then in the lab, we insert a vector so that we can program the T cells to go after CD19. Then we grow up this population of T cells, so it's like growing an army for your immune system. Then the patient is given chemotherapy and the CAR T cells are returned to the patient. This has been very effective, and I hope that CAR T cells will be approved for patients with CLL at some point in the next couple of years. Of course, there are some toxicities, including cytokine release, which means overactivation of the immune system that we can talk about if you guys have questions. So I've tried to highlight the current treatment options, including classic chemotherapy, immunotherapy, and targeted agents. I've talked about some of the new treatment approaches, including combinations of the new drugs, early treatment, new targeted agents, and CAR T cell therapy. Although there are tons of different clinical trials that are open today. And so before you start on a new treatment, I would advise you to ask your doctor if you qualify for a clinical trial, because all the current treatment options that we have are really available because patients like you participated in a clinical trial and showed that these drugs are really a benefit for folks with CLL. So that concludes my part of the presentation. I will hold the questions until our question and answer session, but I would be very happy to introduce now our representative from the Huntsman Foundation. His name is Brandon Plew, and he is a patient with blood cancer himself. And I'd just like him to give you a message coming up next. Thanks for your attention.
Hello, my name is Brandon Plew. I work for the Huntsman Cancer Foundation, and I'm actually a patient as well for the Huntsman Cancer Hospital. So I just wanted to introduce myself and let you know that if you're interested in supporting the work that goes on at Huntsman Cancer or with CLL, I would be more than happy to assist you in that endeavor. So there's a few different ways you can contribute to supporting the work that's going on. We take, money donations, but also if you're looking to participate in any of our events, you can absolutely do that. And another option is just to share your story. So we're always looking for people who have interesting stories, who kind of want to spread the word about, awareness and in this space. And we'd love to have you do that. So my information is going to be up on a slide here. And I'd love to hear from you. So if you have any questions, or another option is also just to reach out to your network. So sometimes you might not have the capacity to support the work, but you might know someone who does. And we'd love to have your help. So thanks so much and appreciate your time.
Wow, a lot of great information there. That was just amazing. I want to thank all our speakers for their information and their helpful presentations. And people have been vigorously answering questions. And I may revisit some of those so they're kind of publicly aware of those questions so that everybody can get the benefit of that. We're going to try to get to as many questions as possible, and feel free to add them as we're going now. If we're not able to answer your question now, you can send them into our Ask the Expert email address that we'll share after this event, and we'll share it on our closing slide. So I'm going to start with some questions. And the first one I'm going to ask is to Stephen, who's our patient representative. And you had this, as a very young man, you had a catastrophic spinal cord injury that led to paralysis. How did that inform you and prepare you for the CLL diagnosis? And you talked, kind of about a deep issue about, we all know that we have this limited time. As a young man in your 20s, were you thinking about those things, or was it later with the CLL? Just take us through that journey, because it's quite a unique and informative journey, I think.
Thank you, Brian. That would take up the rest of the day. So I'll see if I can get to the point. So I became spinal cord injured when I was 23 years old, paralyzed from the bottom of the chest down, so complete paralysis, no motor function, no sensory function whatsoever. So I was a chiropractic student at the time, which is a separate story, but I had amassed a reasonable amount of healthcare and biology language. So that helped me interface with the doctors that were treating me for my spinal cord injury. I kind of always thought that was done. I paid my dues. I was never going to have another serious diagnosis in my life. So I was surprised when I got my CLL diagnosis. But I did have the background, again, of working and interfacing with doctors for decades prior to my injury. So in that sense, it was helpful. I also wanted to say a little bit about, what really prepared me most for my treatment. And that was attending the first patient education forum for the CLL Society at City of Hope, which I think I mentioned in my presentation. Around just a few months prior to that, I had a bone marrow biopsy and discovered that my bone marrow was quite congested with CLL cells. And my doctor said that treatment was more or less inevitable in a short period of time. and I was hedging, and partly because of my spinal cord injury. What about it? Well, as Dr. Stevens mentioned, the adverse effects of BTK inhibitors include arthralgia and diarrhea. Well, I'm completely reliant on my arms to get around. So if I was going to be subjected to joint pain, that was a concern for me. And because of my spinal cord injury, I'm incontinent of bowel and bladder. I manage it without any issue, but the treatments for CLL could have thrown that into a quick downward spiral. And when when my doctor told me that treatment was inevitable, I was kind of hedging. Let's see if we can just put this off as long as possible. And he presented at the first patient education forum, and I got to see him in his element. And there was something about that moment that it gave me an assurance that I was ready to go forward and was going to take whatever, and deal with whatever happened. I was fortunate. I didn't get any arthralgias. I was also fortunate. I never had any issues with diarrhea or any adverse effects from the ibrutinib that I was treated with. So for me, my CLL story, I think, has a happy ending. Again, I was treated for 1 year in 2017, and I've been symptom-free and in a complete remission since.
Thank you, Stephen. Dr. Hu, could you talk a little bit about the issues of a couple things that I think have gotten scant attention in terms of, people early on in their disease and stuff, and that's osteoporosis. Is there things that we know? We know that CLL patients have higher incidence. Is there anything different about treating that? If that's something that you want to address, that would be great. And the other question was, we all know CLL patients, regardless of their therapy, are immunocompromised. Is there a way patients can quantitate that? Are there tests that they can get done to say how? And anybody could take that second question, yeah.
Yeah, I might defer the osteoporosis question to either Harsh or Debbie. I'll just say, in general, our treatments for blood cancers and the disease itself probably predisposes us to getting osteoporosis, mostly because the CLL is in the blood and also the bone marrow. So there can be some advanced osteoporosis in that way, but also the treatments itself can also accelerate it as well. There's regular screening testing for osteoporosis over the age of 65, I think, with DEXA scans. And if somebody is osteopenic or osteoporotic, then there are CDC guidelines about essentially how to treat with either vitamin D or calcium supplementation, and also more advanced bisphosphonates like Zometa or Prolia or any of those other advanced medications. But I don't necessarily know of any specific recommendations to CLL, but maybe my colleagues can chime in on that.
Yeah, I'd be happy to talk a little bit about this because I'm super excited about researching osteoporosis in folks that have CLL, just because what I started noticing in my clinic is people would come in and they would get something called vertebral compression fractures. And that essentially means, your vertebrae are shaped kind of like a little rectangle, and they came in and they did something simple, like they bent over in their garden and all of a sudden they had this severe back pain, and on the scans their vertebrae had collapsed. Now I don't want that to be terrifying because it's still very, very rare. I just see a lot of folks with CLL in my clinic, and I just noticed that was happening. And so looking in, there's a really big national database that was used to look at that, and did find an increased rate of vertebral fractures and osteoporosis in people that have CLL. And I don't think that our current methods or preventive methods might be the best yet. I think it needs a little bit more research, because what I'm finding is, once somebody gets one of those vertebral compression fractures, they're automatically diagnosed with osteoporosis. But I always send them to get DEXA scans at that point, and a lot of times their readings are in the osteopenic range. And so I don't think that it's a perfect.
Remind us what osteopenia is, if you could.
Yeah,
please.
that's kind of in between normal and osteoporosis. So the bone density is kind of in that mid-range. So not quite qualifying, not low enough to be osteoporosis, but kind of in that mid-range. And so I think that there's probably something to be said about the bone structure, with the CLLs kind of taking up a lot of the bone there in the marrow. And sometimes I find that if you have a lot of CLL in the marrow and then you treat the CLL, you know, all of that leaves the bone and then the bone isn't quite as strong. And so sometimes this happens like after we start therapy for CLL. And so I'm doing some research with one of the radiologists actually at the Huntsman, and we're taking some bone marrow samples and looking at the composition of bone in people who have CLL, people who have active CLL, and people who are in remission with CLL, to try to see if we can figure out, you know, is there something special about the osteoporosis that happens with CLL? And I suspect there will be. And so I think we're not good enough at our preventive recommendations yet. And so more to come, but it's an area of active investigation.
Dr. Shaw, do you want to take I think I know the answer to this, but is there any testing, or, I mean, we say we're all immunocompromised. You know, what do you do in terms of working that up, or is it just an accepted fact, no workup? Just what does that mean?
Yeah, I mean, you know, obviously, as we know, all CLL patients are inherently immunocompromised. I mean, there's one objective thing that we do is, if people have recurrent infections, we do check their immunoglobulin levels. And if they're consistently below 500 and in presence of, you know, a lot of infection, then we may start patients on monthly IVIG infusions, which can help in preventing these infections.
And remind us what IVIG is.
It's intravenous immunoglobulin, which you know, it's basically just helping your body in terms of, you know, it enables your body to make antibodies against several infections.
Yeah. Do you want to, there was a question here about the difference between CLL and SLL. Dr. Stevens, did you want to take that?
Yeah, I think it's always a confusing term, because of course chronic lymphocytic leukemia and small lymphocytic lymphoma, and it gets people confused about, you know, do I have leukemia? Do I have lymphoma? And the fact is that CLL does behave a lot more like lymphoma than it does the other types of leukemias. However, the cells are exactly the same kind of cells. It just matters where they are. So with CLL, they're more circulating out around in the blood. You have a high white blood cell count when you get a blood count done. Whereas with SLL, they're more located in the lymph nodes. So when I'm explaining this to my patients, I always think of, you know, imagine a CLL cell as a couch, and your couch is in your living room. If you move that couch to the basement, it is still a couch. And so in my opinion, they're interchangeable. All the treatments should be the same for both CLL and SLL.
I'm going to stay with you here, Dr. Stevens. Clinical trials, if somebody's, tell us how you enroll in a clinical trial. Specifically, how would you enroll in a clinical trial at the Huntsman? And if you could talk a little bit about your skin cancer. You did talk about it in your presentation. What's involved in that trial specifically? What do you have a way for people to get their lab done elsewhere, telehealth? Because not everybody is lucky enough to live in Salt Lake City, so they have to, you know, would have to travel significant distances sometimes. Is there a way you can help people who would have to jump on a plane to see you in a clinical trial?
Yeah, absolutely. So as you've probably seen with all of our different presentations, we've talked about clinical trials for people who need treatment. We've talked about clinical trials for people on watch and wait. And, you know, so there's a lot of different kinds of clinical trials. So sometimes you don't know until you ask your doctor what's available. And then also there's a website called clinicaltrials.gov that you can go in and you can search by CLL, and you can even search by your area to see if there's any clinical trials that might be interesting. And also, you know, a CLL Society can help with, you know, helping you find a clinical trial for you. There's also other programs like Lymphoma Research Foundation or Leukemia Lymphoma Society that can help kind of direct you in the right direction if you want a clinical trial in your area. But usually what's involved on a clinical trial is some sort of screening. So you have to make sure you're a candidate for the study. So a lot of times that might involve CT scans, maybe a bone marrow biopsy, usually labs and an exam and evaluation by a doctor. And once you qualify, then you might, you know, let's say it's a treatment trial, you would get put on treatment. And when you're talking with your doctor about clinical trials, you want to ask what's paid for by the study, because some of the things that we do on study are considered standard of care, like, you know, complete blood counts and things like that, and those might still get billed to your insurance. But a lot of times the drug being studied is actually paid for by the study, so it does you know, provide a good advantage to people. They don't have to pay for it. Their insurance doesn't have to pay for it. That's not the case in all studies. So some studies, the drug is already approved, and so people do have to pay for it through their insurance. And, you know, ask if there's any support for travel. So for example, since here at the University of Utah, we serve essentially a 5-state area, which I think when I last found it was about 15% of the continental US. And so we are very set to do clinical trials for people who don't live right in Salt Lake. So when I negotiate contracts for clinical trials, I always negotiate travel costs for patients as well. So for example, usually we have hotel rooms paid for if it's required to be there, you know, multiple days for study, usually gas reimbursement pending on how many miles you live away from the cancer center. And then the other question about using local labs, that's often possible, but you know, you would just have to talk with who's ever seeing you to see what's possible to do locally, because if it's kind of like standard labs, like we just need a blood count or something like that, something that can be done anywhere, that can usually be done locally. We have had a little bit of a setback in virtual consultation. During COVID was really nice because most of the states said it was a state of emergency. And so we could practice wherever our patients were, meaning we could do virtual visits anywhere. But now that those have all closed, it is technically illegal for us to see patients in another state. So if you're sitting in your office in Wyoming, if I don't have a Wyoming medical license, I'm legally not allowed to see you. And so, you know, some of those things we work around. So like, for example, I have an Idaho medical license just because we're very close to Idaho. A lot of our patients travel from there. So I can still do virtual visits, for example, in that state, but it's a little bit complicated right now. So we'll just have to talk to the doctor about it. And then you did ask a question about nicotinamide clinical trial. What we're doing on that is we are enrolling people who have a diagnosis of CLL or SLL that have had a non-melanoma skin cancer, so basal cell or squamous cell skin cancer within the last 5 years. And what we do is we enroll people, and people get randomized for the first year to either take nicotinamide 500 milligrams twice a day versus a placebo twice a day for a year. We do skin cancer exams with one of our dermatologists and biopsies if anything looks like it needs to be biopsied every 6 months. And so at that year mark, we will unblind people. What that means is we will tell you you've been taking nicotinamide for the last year, or you've been taking a placebo. And then for the next year, everybody takes nicotinamide. So you get an additional year of nicotinamide. And then those skin cancer and clinical exams, they happen every 6 months for that first 2 years. And then there's another one at 3 years after you've been off of the nicotinamide for a year.
So the nicotinamide is not lifelong then? It's just a 2-year intervention? Is that what you're looking at?
Yeah, in this particular clinical trial, I think there's a lot of research about timing and how long does it need to be taken. And the original clinical trial that showed in people who didn't have immunosuppression or CLL that this prevents skin cancer, it was given for a year in that particular trial. And so so I'm not sure yet the right amount of time to take it, but that's part of what we're studying on the trial.
Dr. Hu, when is there a white count level that you would say to a patient they need treatment for their CLL, assuming they're doing well otherwise? If they reach 100,000 or something, time to treat, somebody was asking what level of white count do I need treatment for my CLL at?
Yeah, generally none. I mean, I have one patient that had a white count of 300,000, I want to say for like 3 years, and there was no treatment given. She eventually got treatment because of increasing spleen size and some symptoms. And so, we really do, it's really based on the patient, right? So it's a lot of it is treating the patient, not the numbers. So in order for us to treat the patient, it's really gauging whether a patient has symptoms because of their CLL, attributable to their CLL. And that really overrules what the other numbers say. I have patients with red blood cell or hemoglobin numbers in the 9s. They feel fine. They don't really want to start treatment. And I think it's totally fine to observe them at that point. So it's really patient dependent. If that same patient came into me saying that they had debilitating fatigue or just didn't have energy to do their usual activities, then that might be time to start treatment. So again, it's not necessarily a categorical number. I will say that the one maybe exception that we may look at is if the rate of acceleration of the white blood cell count, so it's really doubling very, very quickly, then we may consider treatment. However, if it's doubling quickly, sometimes that'll be attributed to more symptoms. Like we'll see a patient developing more anemia, or lymph nodes are growing quickly and producing symptoms. So I would say it's not necessarily a categorical number, but if it is going up very fast, we may still institute treatment for that reason.
Dr. Shaw, there's a ton of questions on COVID. Let me focus in on vaccines first. First, can you kind of just quickly summarize the efficacy, what we know about the efficacy of the vaccines, and specifically if you're on treatment, if you're on a monoclonal antibody, what do we know about that, and what are you advising your patients now about the vaccines?
Yeah, very good question. So, obviously earlier in the pandemic, the variants were more Delta, and now we have more Omicron variants, right? So for that reason, the bivalent vaccine was developed to help protect against those variants. But as we go on, there are more and more variants that are coming up that are not, covered by the vaccine. So there is, obviously there is work being done in clinical trials with newer vaccines and newer versions of Evusheld to sort of to cover all the variants. So that's where we are with the vaccine. So we would recommend everyone to get the bivalent vaccine because it can protect you against the newer BA4 and BA5 variants. Although as we know, there's BQ variants that are coming up. As far as the duration between anti-CD20 monoclonal antibodies and getting the vaccines, we know that when patients are on anti-CD20 monoclonal antibodies,
so we're talking about rituximab and Gazyva mostly, here.
They may not be able to mount a response to the vaccine. So for that reason, we would still recommend getting the vaccines, but we would recommend, getting Evusheld, which, obviously is a cocktail of antibodies that are already made. Although we are now realizing that Evusheld is not covering against all the variants. So, I think those recommendations may be changing in the future.
Yeah, we say stay tuned because right now we're still recommending Evusheld. We're still recommending Bebtelovimab, depending on what the variants are in your community. But I'm not sure we're going to be doing that by the end of the year or even sooner. It's just things are changing so darn fast. So just kind of stay tuned.
Yeah, and just today at University of Utah, we have stopped starting today to not give the bebtelovimab monoclonal antibody because of the variants in Utah. So this was just a change that was made today.
To CLL patients, one of the problems for the vaccine for some CLL patients, and tell me if there's others that I'm thinking of, but I've heard a lot of people get swollen lymph nodes significantly after being vaccinated. Could you talk about that and any recommendations or concerns about that? And are there any other special concerns? Do people's counts go up, down, anything that we know of generally? Because I hear all these anecdotes, you know, I had the shot and my CLL got better or my CLL got worse. And do we have any data on that? But also address the lymph nodes, which seem to be a pretty common problem after vaccinations, not just with COVID for CLL patients. Yeah.
Yes, you know, the lymphadenopathy reactive to the COVID vaccine is common in even patients who do not have CLL or patients who have other lymphomas. Usually, the symptoms from the lymphadenopathy, you know, they're self-resolving over the next, you know, several days. Additionally, you know, patients can also develop fevers, and you know, local site pain where the vaccine was given, and in majority of the cases these are self-resolving. As far as sorry, what was the second question?
Just if there were any other significant reactions that are specific to CLL patients to the COVID vaccine.
Yes, so I have seen in some patients where after the vaccine, if I check blood counts, there may be some decrease in maybe like hemoglobin or platelets, or there may be some increase in the neutrophils, or even decrease. So I've seen variations. I don't know if maybe I don't know if Debbie has, Dr. Stevens or Dr. Hu has seen things otherwise, but you know, I think usually those things are also sort of, you know, they correct themselves. But we do see with COVID itself, the COVID infection itself can suppress blood counts. It can suppress hemoglobin, white cells, and platelets.
We're going to close up, and I'm going to ask, rather than asking everybody to give a final word here, I'm going to ask and put two people on the spot here. If Stephen has any final advice he wants to give, and Dr. Stevens, and I'll give you the last thoughts if there's anything that you want to make sure that people take away from this. So Stephen, you want to go first? Stephen Feldman, yeah.
Yes, I would recommend that everybody watch this presentation again once it becomes available. And just a reminder that previous CLL Society patient education forums are also available online. I think watching and reviewing is the best way to get yourself up to speed and to learn learn all of the terminology that can be a little bit overwhelming at first.
Dr. Stevens, last word to you.
Yeah, I first want to start out just by thanking all of the speakers and the CLL Society for making this event happen again. I also want to thank all of the patients for asking really good questions. There's so many questions. We haven't even been able to get to all of those. And I just really appreciate your participation in this. And I commend you in taking a step to really, you know, take control and get knowledge about your CLL. And I think that can only help you in deciding on treatment options and deciding what you want to do, how you want to live your life. And I hope that you gained by this that there is a lot of hope for people who have CLL. I talked about some of the great treatments that we have. I didn't have time to talk about all of the great ones. And so usually, you know, your doctor probably is going to have a plan A, a plan B, a plan C, a plan D. And so the benefit of that is you have so many options. You can choose what fits well with your lifestyle. And so I just wanted to say thanks again for, taking the time to be with us today.
I want to thank all our speakers. I want to thank our audience. Our motto is smart patients get smart care. And I think everybody is leaving this session a smarter patient. There were a ridiculous number of questions that we couldn't get to. Not ridiculous questions, great questions, but a large number of questions. And so we'll try to get through to those who are asked and put those in the Ask the Expert. This program was made possible by the support of our sponsors. We'd like again to thank AstraZeneca, Beijing, Bristol Myers Squibb, Janssen, and Pharmacyclics through their grant support. Again, thank you. Please complete our post-event survey. I want you to know that we read every comment that you put in. We go through the data with a fine-tooth comb. It's extraordinarily helpful to us. We share it with all our speakers. If there's things that we can do better, believe me, Dr. Stevens and I talk about this stuff. What did they say? We try to change things. Notice that the topics were different this year. That was your feedback. If there's things we're not getting to that you want us to get to, you want more time for Q&A, less press, you let us know. We'll try to respond to those things. So please let us know. We have a couple exciting events coming up. I think a lot of people know Dr. Nicole Lamana. She is just great, and this is no slides, no nothing. This is just throw out a question, and Dr. Lamana will offer that, and you'll get to meet Doreen Zetterland, who is a long-term SLL, CLL patient and a great patient advocate. And beyond that, save the date, January 12th. January 12th, we're doing our next event on COVID-19. And this is interesting. We will not have a hematologist at this event. We will have an immunologist who specializes in the immunocompromised patients, and we'll have an infectious disease specialist. And this is going to be particularly important because I predict by that time we will not have an active monoclonal antibody for pre-exposure prophylaxis. Evusheld will probably no longer be accessible, and bebtelovimab, if you heard today, breaking news, will likely not be accessible. So December 5th and January 12th. Please think about that. Send your questions to asktheexperts@cllsociety.org. Easy to do that. Please, there's an on-demand version of this, which is a little bit longer. We cut out some time to allow more Q&A, so you can hear some of the talk, some of the missing slides and stuff will be presented. So it's a longer presentation that you can do on your own time. And that should be up, usually at the most in a week from now. So be sure to do that. Be sure to do the survey. It is the giving season. We're very grateful for your support. We're very grateful for your attendance. The CLL Society is invested in your long life, and please invest in the long life of the CLL Society by supporting our work. We have a donate page on the website. We're extremely grateful, and you can reach out to us with any questions or any concerns. So happy Thanksgiving to everyone. Thank you so much to all our great speakers. Another successful event from Salt Lake City. It's so great to work with Huntsman. It's an incredible center, and you're doing such groundbreaking work in CLL. We are so grateful. Thank you.
Thanks, everybody. Happy Thanksgiving.
Thank you.
Thanks. Bye.